Good evening, everybody. I'm Dr. Pratik Tambe, Chairperson for the EMOG's Endocrinology Committee, welcoming all of you on behalf of Science Integra and our academic partners for today, Bharat Serums and Vaccines, who through their Bridging Bharat initiative have done wonderful services during this lockdown period, during pandemic, to bring academics to all of us from the different far-flung corners of India. Today's program is in association with the EMOG's Endocrinology Committee, for which we thank our esteemed President, Dr. Nandita Palchetkar, President of EMOG's, Dr. Arun Nayak, who is our Secretary of EMOG's. Both of them have always been pillars of support in all our academic and scientific endeavors, and we wish to place our gratitude and record towards them. I would also like to thank our co-convener for today, Dr. Archana Verma, for giving me the opportunity to talk to you at the beginning of the program. Today's program is in association with 4 OBGYN societies, namely Rewari, Jhansi, Dehradun, and Gwalior. Many of their office bearers are tuned in today and they are present as faculty during the program. I'd like to take this opportunity to welcome all of you, extend a courteous and warm welcome to all our distinguished office bearers. I see Dr. Leela Vyas Madam has just joined in. We missed you in the last program, ma'am. We are so happy to see you today. Thank you so much for joining in. And without further ado, I would like to hand over for the introduction of our 4 chairpersons for today, Dr. Leela Vyas, Dr. Seema Mittal, Dr. Anna and Dr. Meenu Vaish. Can we have the slides of the CV introductions, please, so that all of them will be formally introduced?
Okay. Right. चलो ठीक है
Hello. Yeah. Hello. Am I audible? Yeah.
Yes, ma'am, you're audible.
Good evening, everyone. I'm so happy to be among all everyone here, and very happy to introduce Dr. Leela Vyas. She happens to be from my alma mater college, SMS Medical College, Jaipur, and so happy, ma'am. Good evening. And she knows me pretty well. She was VP in 2008, Vice President of Foxy 2018, and former professor and unit head of Zadana Hospital, IVF consultant, member of research review books, senior consultant at Cocoon Hospital, and chairperson ISA 2020, President NARCHI, and she has been president of Jaipur Obstetric and Gynae Society in 2013 and 15. She is a very dynamic lady. We have always seen her very actively participating in all the AICUGs. I think we all know pretty her very well. Welcome, ma'am.
Thank you. Thank you.
Next slide, please. Can we have the introduction of Dr. Seema Mittal?
Yeah, so I really again I welcomed another doctor, Dr. Seema Mittal, and she's director of Lalita Memorial Hospital Private Limited, Rewari, and infertility specialist. She's practicing gynecologist and obstetrician in Rewari, professor IVF Center in Haryana, has been president of Rewari Obstetric and Gynae Society. I think she's still president, or Secretary Doctors for Society, and past Treasurer in Indian Medical Association Rewari, Executive Member of IFS Haryana, received award from President for her book, Sukh Matritva. Welcome, Dr. Seema Mittal.
We'd like to hand over to the chairpersons and request them to introduce the first speaker of today, who is none other than Dr. Archana Verma, the dynamic lady behind the conceptualization of this entire program. Can we have the introduction for Dr. Archana Verma, please, on screen?
Can I start?
Yes, ma'am, of course. Please go ahead.
Yeah. At the outset, I convey my sincere thanks to MOGS and Dr. Archana, who is the convener for the All India these programs. And Pratik, thank you very much for giving this opportunity. And बिल्कुल ऐसा ही लग रहा है स्पेस में बैठे हुए हो. So now your next program is to go to Mars or where?
Sure, ma'am.
So it's my proud privilege to introduce Dr. Archana Verma. She is a very, first thing is a beautiful person by heart, and we all have seen her as a public awareness person. So she is a public figure among the Foxians. I think all the members, 40,000 members, everyone must be knowing her since her work in public awareness committee. But now she is, now we will change to your the president, vice president elect North Zone for 2021. And in her credentials, we see that so many awards she has taken, and she is always doing work for the Indian females. She has been associated with all CRPF people for their females, means either their spouse or the female staff of that. She has worked for them so nicely, and very dedication she had. She had worked with these menstrual hygiene, and she can organize. If you just let her, just one thing is, all the viewers, I just convey that if anyone wants any program in their own city, because now they online she can reach everywhere. So just drop a mail or just give a WhatsApp. I think more friendly with the WhatsApp, and give a WhatsApp that ki, Dr. Archana, we want to this thing. The very next hour you will get that whole program is made, and she will do this thing. So with this, all a dynamic vice president elect, we are waiting for the next year. So many work we are just will do with you. Hope you will give us all chance to work with you. So I invite Dr. Archana to for her lecture.
Before Dr. Archana starts, I have a small announcement to make. We have amidst us our guest of honor, the dynamic lady from Telangana, Vice President-elect of Foxy, Dr. Shanta Kumari. Thank you so much for coming, ma'am. We are really privileged to have you with us. As already introduced, Madam is the President-elect of Foxy. She is the chairperson of ICOG from 2018. She's been Secretary of ICOG in the past, member of the FIGO Working Group on Violence Against Women, Vice President of Foxy, and Secretary of the Telangana Society, IAG Managing Committee member for several years. Please, ma'am, bless us with your pearls of wisdom.
Thank you, Dr. Pratik. Really, hi, Leela. Nice to see you after a long time. So I have to be very honest. Dr. Pratik called me in the afternoon and told me about this program. Actually, it slipped off my brain. So thank you, Pratik. I really was listening to Leela. Leela, you are very right. I think now this virtual world is connecting all of us together, and that is what is actually keeping us all, I think, okay, fit and fine in this days of pandemic. At least when we see each other and all. So congratulations to the whole team. I can see a whole lot of societies, Rewari, Jhansi, Dehradun and Gwalior. Okay, Gwalior, Dehradun, Rewari, I have been. Jhansi was the only society I was supposed to go there, but they had some day and night cricket match that day when I was supposed to go. So that my program couldn't be fitted in. So probably maybe next time when I come that side after the pandemic, I would be lucky enough to visit Jhansi, which is a very, I think, and it's going to be a memorable place. I always wanted to visit that. So all the best to the whole team. I have, I think, all the faculty. We've got Archana, Verma, Pratik, Tambe, Asha Jain, Varsha, Lahade, and a whole lot of panelists. I think please enjoy the academics and all the best.
Thank you so much, ma'am.
Yes, madam. Actually, after once the result were out, and the Asha Jain, who was supposed to arrange this with us and you as a chief guest, and so then after the results were over, she was a little bit that thing. But I told her not to worry and go ahead with everything. And so you were our first choice always, and we were planning this with. And then Pratik said, "We will be doing very nicely." And Pratik is the best organizer possible, so we any important program I want to do with the Pratik only. Madam, and thank you very much for coming.
Thank you, ma'am. You can start sharing your slides, please.
Thank you, Dr. Leela Vyas, for giving such a elaborate, or rather good words for me. And so I will start right now, because today we are very strict that we won't be wasting any time. Dear friends, we all love chocolates, and chocolate is a happiness that you can eat. And one of the that thing only and only which girls like. But is it same for the gynecologist? No, it can be a nightmare. So today I'll be talking about the chocolate cyst of the OP. And the chocolate cyst of the OP are actually the ovarian endometriomas, which are filled with. Hello, am I audible? Hello.
Yes,
Okay.
yes, audible.
They are filled with the chocolate color fluid. That's why that their name is a chocolate cyst, and they can be either unilateral or bilateral, and they can be symptomatic also, irrespective of the size. And pain is the feature many times, and 50% of the patients, they are infertile. And because it's such an enigmatic disease, the diagnosis is not all that simple. So how to diagnose the and how to think about it, that is it endometriosis? So there are certain clinical features. There are 7D. If you remember, the pain is the main presenting feature in the endometriosis. And this is that there are 7 type of pain: dysmenorrhea, dyspareunia, dysuria, dyschezia, and dysfunctional uterine bleeding also there, and difficulty in conception. And the pain is so many times the diffuse abdominal pain all the time, and cyclical, generally cyclical, and sometimes even the non-gynecological pains are also there. And when you examine the patient, the signs after the symptom, there are certain signs. When you examine a patient, there is a pelvic tenderness, and you find the uterus to be very fixed and retroverted, and there are nodularities of the Douglas pouch on the Douglas pouch and uterosacral ligament, and ovaries may be enlarged and tender, and you can feel the ovarian cyst also. And this PV examination or bimanual examination may not be appropriate in younger adolescents and unmarried, and one has to suspect endometriosis even if there are no signs. So then after this thing, we have certain medical technologies to support our diagnosis. One is a transvaginal sonography, another is a magnetic resonance imaging or MRI, and the serum biomarkers, they are the CA125. And this transvaginal sonography actually is it's recommended that one can diagnose or exclude an ovarian endometrioma with the help of a TVS. And the perimenopausal patients, the clinical features, not clinical, the ultrasonological features were described by Ventolsbeke et al. In 2010. There, the ultrasound characteristics are mainly number 1, ground glass echogenicity, and 1 to 4 only compartments, and no papillary structures with detectable blood flow. And when one has to be very good, and sometimes skilled ultrasonologist is needed to confirm the diagnosis and to look for the deep infiltrative endometriosis and other pelvic organ endometriosis also. It is very important. And there's one sliding sign also, when you move the transvaginal probe, then those that is peritoneum, which in between the bladder and the vagina, it is not fixed type. If it is negative in sliding, it is good prognostic sign. And then the role of 3D and MRI is recommended, that it is the role of 3D, and they are not well established, and the usefulness of the MRIs is also in all the cases is also not established. And then laparoscopy, about a confirmed laparoscopy with biopsy and histopathology is the gold standard. laparoscopy is recommended to diagnose endometriosis, although evidence is lacking that positive laparoscopy without histology proves the presence of a disease. However, a negative histology does not exclude it. And there is a role of a diagnostic lab with the see and treat also, because only diagnostic is not good. Exclude it, or it helps in taking biopsy, and so exclude the rare instances of the malignancy also. And because laparoscopy is an invasive procedure, so the consent getting the consent for it is difficult, and we have to only anticipate it. And pre-operative good imaging of bladder, bowel and ureter is preferred before doing and jumping for any laparoscopy. And so now how after the diagnosis, we see that there are challenges at every place. That endometriosis is really a challenging disease and requires decision making at every stage by the clinician and the patient. Even the patient, they get fed up with the management and with the pain and with the problem and the recurrence also. So in the endometrioma, they are medical, surgical, and mainly medical and surgical management, and the infertility management is left. Among the medical management of the endometriosis and endometrioma, there are many options, mainly hormonal contraception, and progestogens and anti-progestogens and GnRH agonist. So because many options are there, and the recommendation are that it is recommended to prescribe hormonal treatment and this hormonal contraceptives, progestogens, anti-progestogens or GnRH agonist, all of them as one of the option, as it reduces endometriosis associated pain. So mind it is for the pain also. And this guideline development group, it recommends that clinician take patient preference also, and side effects and efficacy and cost and availability of the medicine into the consideration when choosing the management for this endometriosis associated pain. Regarding the COC recommendation, this is actually it really helps in reducing endometriosis associated dyspareunia, dysmenorrhea and non-menstrual pain also. And we can use it, the main advantage is this, we can use it continuously also, and those who are having dysmenorrhea and we can consider the use of vaginal contraceptive ring or even the transdermal patch. This will also help. And because it is so much readily available, and the patient also accept it, and it is not very costly. And regarding the progestogens, the recommendation are that we can use progestogens that like medroxyprogesterone acetate, either oral or depot, and dinogel cyprotron acetate, norethistron acetate, or danazol, or anti-progestogens as one of the options. Though I have never used anti-progestogens, and danazol nowadays is not being used. And this guideline group again recommends that one should take different side effect profiles of progestogens and anti-progestogens into the account, especially the irreversible side effects like thrombosis and the androgenic side effects. And clinician can consider prescribing a levonorgestrel releasing intrauterine system like Mirena is one of the options to reduce endometriosis associated pain. Dear, I am again and again telling this endometriosis associated pain only, because there we have to exclude other kind of pain also. And then there's a one very important and almost everybody want to use and is quite afraid of using is the GnRH. And the recommendation is that we can use GnRH agonist with very many branded name like neferlin, leupride, buserelin, goserelin or triptorelin as one of the options for reducing endometriosis pain, although the evidence is limited regarding dosage or duration of the treatment. And it is also recommended that we have to add a hormonal add-back therapy, which should coincide with the start of the GnRH agonist therapy. This is not to improve its working, but just to prevent bone loss and the hypoestrogenic symptoms during the treatment, because patients sometimes complain so much of those menopausal like of symptoms that it becomes really hopeless condition for the patient and the doctor also. So it's better to use it, add it. So, and this GDG, these are actually ASHRAE recommendations, and the clinicians to give careful consideration to the use of agonist in young women and adolescents. This is the group of the patient where we cannot use it, rather we should avoid it, because they have not reached the maximum bone density. And now again after all these hormones, progestogens and GnRH are the COCs and progestogens are still our first love, or we have jumped onto the something else, कुछ नया आया क्या market में या वही पुराना. So there is a new product, Dynogest. So Dynogest, though not a new, but there are certain newer analog also. This is SPRM is a Dynogest and GnRH antagonist also, and aromatase inhibitors are also nowadays being used, and cabergoline is also used, and ulipristal acetate and mifepristone. Mifepristone, so many clinicians, they like to give in around 50 milligram of the dose daily. And this Dynogest is actually being recommended and seen that this is one of the best medicine available, and these are actually the progesterone receptor modulators, and they act on the they reduce the gonadotropin secretion and estradiol level, and so the estradiol level is decreased. And because this endometriosis is an estrogen dependent disease, it really helps, and it causes apoptosis of the ovarian lesions. And this particular study, this Dynogest has been found to be effective in reducing the endometrioma and the chocolate cyst size also. And it was given for a very long time, for around they were used this pain score. This VAS score is actually a pain score, and the side effects were also noted. And from 56.9 millimeter, the size was reduced to 11 millimeter, and the side effects were minimum, only mild to moderate, mild only. And this is this long-term treatment of endometriosis. It was published in an International Journal of Women Health. And so the worldwide Dynogest is the first line in management of endometriosis, and it is recommended by American Society of Reproductive Medicine and ASHRAE and RCOG also. And so the after this, even if so many medicines are there, but still one is confused, and the patient is also not satisfied. So what next? So the surgery is sometimes required. So and then the surgery, the laparoscopy is a choice, and the pain severity, if because there may be the pain may be very, very sometimes distressing, or they may be because of the rupture, there may be some emergency, and too much of pain, so you have to operate upon it. And then the size of the endometrioma and the patient concern for infertility, or any suspicious finding on TVS regarding the maybe chances of malignancy or some abscess if is there. And in the surgery for the endometrioma, ovarian cystectomy is the choice, and but we need to remember that ovarian damage is also associated while doing this operation. And if we remember the vascular supply of the ovary, all the vessels are near hilum, and so we have to take care of those. And it is age dependent also. The more the age, the more will be the damage, and the excision is definitely better, and vascular compromise may occur, if you are not taking care of with this vascular supply of ovary. And there is a definite ovarian volume reduction and AFC reduction also there, and AMH reduction was also found. And much depends on the experience of surgeon. So this is to be noted, and more adhesions means more chances of surgical complications. So if we have, if the patient has previous surgeries, or then we need to not in hurry open the patient or do the surgery. So in the challenges in the endometriosis, there are certain challenges like asymptomatic patients and recurrence and ART. So ART is to be given or not. And the asymptomatic patient, they are found even you are doing a laparoscopy and you find that there is a small endometriomas, very small endometriomas, but whether to do it or not. So, but it is recommended that asymptomatic patient, we can leave them. And for the secondary prevention, is for the three things. Number one, either stopping or slowing of the disease, and prevention of recurrence of pain and recurrence of the disease documented by ultrasound or laparoscopy. Sorry, there is some spelling mistake because I was doing it today only. And regarding secondary prevention, the guidelines are there that there is a role for prevention of recurrence of disease in surgically treated endometriosis. Minded, after the surgery, it is really very much recommended, and the choice of intervention depends on patient preference, cost, availability, and side effects, and it may be really needed. And in the endometrioma, which was more than 3 centimeter, after cystectomy should be performed instead of drainage and electrocoagulation. This really helps in preventing the secondary prevention of this dysmenorrhea, dyspareunia, and also the some non-menstrual pelvic pain. And after cystectomy for the ovarian endometrioma in women not immediately seeking conception, a clinician are recommended to prescribe. These are again ASHRAE guidelines to prescribe hormonal contraceptive for secondary prevention of endometrioma. So after this, we can give it to that 18 to 24 months also. And the levonorgestrel releasing and intrauterine system was really found to be very helpful. And this again, as I was telling, that for the asymptomatic endometriosis, no need to treat, just follow up, and 6 month time one can do the again the ultrasound. And then there's a ART for endometriosis associated infertility. Normally you can leave the patient for natural conception or something, but sometimes taking into consideration the age and the patient concern for infertility, and if the tubal function are compromised and there is a male factor infertility, or when their other treatment have failed, so we need to go for it. And the for this, the first and foremost line is a controlled ovarian stimulation and IUI. Both of them need to be combined as it increases the live birth rate. Only IUI will not help. Yeah, only this controlled ovarian stimulation will not be all that good. And the ASRM 2012 recommendation are the younger the patient, less than 35, expectant treatment, and again this IUI and controlled ovarian stimulation, and older patient more than 35, again IUI or even IVF, timely IVF should be taken care. And third and fourth, the resection, ablation, and then drainage, and if failed to conceive, IVF and ET is given. So the infertility doctors, they can very well understand it. And this sometimes before infertility management, there is a question that is that GnRH agonist can be used, and this ADVEC therapy was already discussed. And so in infertile women with endometrioma, there is no evidence that cystectomy prior to treatment for assisted this ART is improves the pregnancy rate. Means as such ekdam se surgery karke ART is not necessary, it is not going to improve that. As such evidences are there. And if it is larger than 3 centimeter endometrioma, then this cystectomy is preferred before ART to improve endometriosis associated pain or the accessibility of the follicles. And this GDG recommend that clinician counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and possible loss of the surgery. This is very important because patient may lose the ovary also, and decision to proceed with surgery should be considered carefully. So dear friends, the take home message is know the delays in diagnosis, suspect endometriosis even if there is no sign, and expertise for the surgeon is really very important. And secondary prevention is also take care of secondary prevention is very important. Management of the endometriosis related infertility timely and the ovum freezing is one of the most concerned. And lastly, I would like to say that please, these are all our chocolate cysts, but still never underestimate the power of chocolate. So, and thank you, dear friends. Thank you so much.
Thank you, ma'am. That was really a nice talk. And
Abhi nice ho to kehna to padegi.
no, but what you discussed about the 7D mnemonic, that was also wonderful. And you had already covered so many things. I remember a case, I had scar endometriosis case after the second delivery she developed. And then we have excised the scar. And then Dino just really helped that patient and she overcame her problem. And third time also she delivered with me, and this time she had a boy, so she was very happy.
Take care of the pain, because so many times the patient attendants also they say drama baji kar rahi hai, so koi problem nahi hai. So that is very important to notify it.
Yeah. Thank you so much.
Thank you.
Thank you, Dr. Archana.
Thank you, Dr. Leela. कुछ बढ़िया सा और कमेंट कर दो चलते चलते.
Very nice.
Before we move to the next person, are there any questions from the audience for the speaker?
We will take later, Dr. Pratik.
Question later.
ठीक है, कोई बात नहीं.
इसको डॉक्टर अलका सेठी मुझे करना है क्या?
हाँ जी मैम, आपको करना है, आपको कन्वीनर है.
Dr. Alka Sethi, who really a great Jhansi ki Rani, and she is a consultant gynecologist from Jhansi, Vice President IMA Jhansi, and Honorary Secretary Foxy Jhansi branch, and member and city coordinator of adolescent health committees. बहुत सारे काम कर रखे हैं. I've given her so many awards when I was doing. She was working with me, and she has the gold medalist girl. And Dr. Alka Sethi, thank you for chairing and thank you for coming.
Next slide, please.
Yeah, I have joined. Am I audible?
Yes, ma'am.
Yeah. There was some connection, got lost. So I think I take this pleasure of introducing our next chairperson, Dr. Meenu Vash. Yes, ma'am. Can I continue?
Yes, please, go ahead.
Yeah. Dr. Meenu Vash is the president, Dehradun Obs and Gynae Society. And besides this, she is the director and consultant at Meher Hospital, Dehradun. She has been running high-risk pregnancies and fertility center for last 30 years and has got Medical Excellence Award by Chief Minister of Uttarakhand in 2018 and Best Doctor Award by UMA. And Dr. Meenu Vash had been the organizing secretary at Dehradun GODS and has actively participated in Green Revolution under Public Awareness Program, which was initiated by Foxy. She has organized several important conferences and camps at Dehradun and has presented many papers in various national level conferences. As you see, the list is endless. And besides this, she is a member of all the reputed societies of India, Foxy, PCOS Society, Image, ART, IFS, SR and all. And Dr. Meenu Vash had been the active member of Foxy for last 30 years. So with this, I hand over for further proceedings.
Next slide, please. We have to still introduce one more person.
Yeah, I get this pleasure to introduce, though she has already been seen on the screen, Dr. Veera Lohia. And Dr. Veera Lohia is senior consultant at Janak Hospital, and she's the president at DOGS Gwalior Obs and Gynae Society, secretary QMPOH. She's the vice president of IM in 2018 and co-founder member of Health Plus Club. She has chaired many sessions in AICOG Corporator in 1995, and she's a member of Lions Rotary and Inner Wheel Club. Okay, then I hand over for further proceedings and let the session be started.
Can I have the privilege of introducing the second speaker? And at the outset, I would like to thank Dr. Archana for including me to chair the session. She is such a dynamic person herself. It's a very important topic which we are going to cover, adolescent endometriosis, and we have a wonderful speaker with us, Dr. Pratik Tambe. As we all know, the etiology of endometriosis still remains an enigma. There are various theories postulated. In India, about 25 million women are estimated to be affected by endometriosis. A survey in Australian girls was seen that 16 to 18 years showed that 93% experienced pain with menstruation, and 21% experience severe pain and are frequently associated with disruption of life activities and especially school absenteeism. So this is the magnitude of problem. And to throw more light on this, we have an eminent speaker, Dr. Pratik Tambe. He has a command over, he has a great command and is an all-rounder. And I would like to read the CV. He has international diploma in advanced laparoscopic surgery, trained in ART in Brussels, Belgium, trained in clinical embryology in London and Singapore. He was a chairperson EMOG's Endocrinological Committee 2022. He's a governing council member, executive committee member ISAR 2021, managing committee member and patron Mumbai OBS and Gynae Society. He was a chairperson Foxy Endocrinology Committee from 2017 to 19, managing council member IAG, MSR, AMC 2015-18, mentor MOGS Youth Council 2014-18. He is a recipient of 15 MOGs and 7 Foxy prizes and awards, namely the Meru Hansotia Best
That should
Committee
be enough,
Award.
ma'am. That's enough. Thank you, ma'am.
I think you have so many books, you have so many 3 Foxy focuses, and the list is very long, and I'm sure it will be more than your talk. So I welcome you, sir. Please start the lecture.
Thank you so much, respected Dr. Alka Sethi. And I'd like to start by placing on record my gratitude to the EMOG's office bearers, Dr. Nandita Palshetkar and Dr. Arun Nayak. Gratitude also to Dr. Archana Verma. One second, I think. Yes, my slides are working. Dr. Archana Verma, my co-convener for today's program. Thank you so much for inviting me to speak on adolescent endometriosis, the challenges and dilemmas that we face. I should also acknowledge the 4 societies and the presidents of these 4 societies, Dr. Seema Mittal, Dr. Alka Sethi, Dr. Meenu Vaish, and Dr. Veera Lohia. Thank you so much for being here and associating with us and being here as chairpersons for my session. It's my privilege to speak in your presence. I like to start usually with a quotation, and here I think this particular quotation from Alexander Dumas is particularly relevant to adolescent endometriosis. The merit of all things lies in their difficulty. When we talk about adolescent endometriosis, it's important to structure what we are about to say, and I've tried to do it in a systematic fashion by first talking about the scientific evidence, guidelines from the international bodies. We talk about the Foxy protocols for practice. We debate the option of medical management versus surgical management. And finally, we'll talk a little bit, though maybe not exactly relevant in adolescent health, about fertility issues and the role of counseling. When we look at the published evidence, there's a huge amount that you will see. There's an ACOG guideline which came way back in July of 2010. The ESHRE guideline has already been extensively quoted from by my previous speaker, Dr. Archana Verma. This came out in September of 2013, and an update is expected any day now from ESHRE, which was to be published in 2020, and it should be coming out anytime now. We also have the Foxy GCPR, which came out way back in Dr. Alka Kriplani's year when she was the Foxy president. Dr. Ramani Devi, who's our current vice president from South Zone, was one of the key personalities who worked on this. And of course, there are other publications like the systematic review in the British Journal, which talks about all the different guidelines which have been published and how some of them fail and how of them are very good at highlighting current evidence, but not very good at showing the way forward. This is the NICE guideline, which was published in September of 2017. And when we at Foxy looked at all these guidelines last year, when Dr. Nandita Palshetkar was president, we tried to bring all of these together and bring something relevant and distill them into key practice protocols and key practice points for all of us normal, healthy, obstetricians and gynecologists who cater to these women in day-to-day practice. We did this by dividing each difficulty into as many parts as is feasible and necessary to resolve it. This is the event that we had in Mumbai, the protocols for practice called as endometriosis vision. We had over 150 key opinion leaders from all over the country, the current and past presidents, vice presidents, chairpersons of ICOG, distinguished leaders. We had the chairperson of the endometriosis committee, Dr. Kuldeep Jain, who was my co-convener for this program. We divided ourselves into 4 groups: the diagnosis, medical management, endometriosis associated fertility group, and the surgical management group. Here you can see Dr. Shanta Kumari, who is today's guest of honor. She was also herself present at this event. And we tried to take regional perspectives. Subsequent meetings in Delhi, where Dr. Alka Kriplani herself was there. You can see Archana Verma in the picture. And we also had Dr. Sonia Malik, a host of other dignitaries were present in Chennai, in Ahmedabad, where we had Dr. Manish Banker himself, Dr. Ramani Devi had come in, and in Kolkata, where we had Bashok Mukherjee and we had Bhaskar Pal also present. Out of clutter, we tried to find simplicity, and through this simplicity was born these 2 books, Endometriosis Vision, Protocols for Practice. They were released at Dr. Shanta Kumari's conference in June and disseminated all over the country. I'll give you an update of what the current evidence and recommendations are based on what these 150 plus KOLs brought together. Now, we've always been taught in our undergraduate years, it's been drilled into our heads by our teachers that endometriosis classically presents with a triad of dysmenorrhea, dyspareunia, and infertility. However, you will realize that when we talk about adolescent endometriosis, obviously infertility and dyspareunia do not come into the picture. So we are left floundering, and maybe this triad is not so applicable in the adolescent age group. The next question that we need to answer is, traditionally we've always been taught that laparoscopy is the first and the gold standard as far as diagnosis is concerned. And furthermore, if you were to take a biopsy of the tissue, you are able to demonstrate changes under microscopy, then that is the gold standard for diagnosis of endometriosis. Should we be subjecting an adolescent girl who is not yet fully grown to undergo laparoscopy? That is the key question that we need to answer. Though traditionally in adults, we've always favored the laparoscopic approach, today there is a paradigm shift and we now resort to non-surgical methods of diagnosis. Today we consider that it's a presumptive diagnosis and we don't always need to demonstrate these classic laparoscopic appearances, especially in an adolescent girl, because we would like to avoid surgery in this girl. You all know what are the different laparoscopic stages, and I'm not going to waste time talking about them because we are all familiar with these, but we want to stress more about what are the non-invasive methods of diagnosis. And 3 key options are available to us. The first is in inverted commas transvaginal sonography, because in India it may not be so relevant. No adolescent in India is going to permit transvaginal ultrasonography. Therefore, it's only a theoretical option. The other 2 options are magnetic resonance imaging and biochemical markers, and I'll come to that in a couple of slides. As far as CT scan and MRI are concerned, if there are lesions which are more than 1 centimeter in diameter, then MRI is supposed to be the gold standard for diagnosis, and especially in this age group, it helps to distinguish between endometriomas from dermoid cysts, which are the other common cysts which are perceived and seen commonly in this age group. If you have extensive disease or you have primary rectovaginal disease, which sometimes presents in adolescents without an endometrioma or other signs of endometriosis, then MRI is supposed to be accurate in more than 90% of cases, especially if you have spread to bowel and to bladder. Can we use biomarkers in adolescents to avoid subjecting the patient to laparoscopy? The answer is both yes and no. Why yes? Because yes, we have biomarkers which are available. No, because in India they are not so widely available, and hopefully over the next 5 to 10 years we'll be able to see a panel consisting of CA125, CCR type 1 mRNA, and MCP1, which is supposed to be more than 92% sensitive and more than 82% specific for the diagnosis of endometriosis. What is more commonly available is CA125 with interleukin 8 and TNF alpha, which is available in some of the major metro cities, which still has a sensitivity of more than 90%. Traditionally, all of us have been taught in the 20-25-year ages ago that CA125 is the only biomarker which is available. However, today we have better tests which are available. We just wait for them to be more widely available to us. Coming to the main topic of the day, which is the management of adolescent endometriosis, where all of us are left with a lot of questions. Should we opt for surgery as a primary modality, as we have always been taught since 20-30 years? Should we go with primary medical management? Should we wait for a tissue diagnosis before we start treating as endometriosis? There are so many questions in both our minds as well as the patient and her parents' minds. So here I want to introduce to you this algorithm which we came up with and which is published in Endometriosis Vision, that today there is a paradigm shift in the approach to treatment of adolescent endometriosis. Where previously we used to say we need a tissue diagnosis or we need the gold standard laparoscopy diagnosis, today we now say that we need to have an empirical diagnosis and go ahead with medical management. If the patient responds to medical management, then the presumptive diagnosis of endometriosis in an adolescent girl is proven and also treated, at the same time avoiding laparoscopy in this young age. If on the other hand, the medical management does not work, then you are not dealing with endometriosis. It may be some other issue. It may be PID, maybe tuberculosis. It may be another issue which you have missed. And then you are well within your rights to go ahead with laparoscopy, identify it, and follow what is commonly called, in inverted commas, the see and treat approach. Coming to the medical management, it's very clearly identified by the American Society of Reproductive Medicine that medical management has a key role to play in 3 clinical scenarios. It is the first choice in adolescent endometriosis, patients with chronic pelvic pain, and those who have a recurrence of disease. However, it is not recommended for treatment in those patients who are trying to conceive, because when you administer medical management, it is going to stop the patient from ovulating, and obviously if she doesn't ovulate, she is not going to get pregnant. So coming to the various options that we have, at a glance you can see from this table that we have a plethora of options. I remember reading way back in our medical textbooks 25-30 years ago. At that time, COCs and GnRH analogs were the only 2 options that were available to us. COCs usually were not acceptable to adolescent patients because in India still there is some stigma attached to an oral contraceptive being taken by an adolescent girl, and that doesn't go down very well either with the patient or with her caregivers, namely the parents and guardians. What is of key interest, I will draw your attention to that last column, that there are only 2 modalities which have high efficacy, and they are, as we said earlier, GnRH analogs, which as a surgeon I have given for 15 to 20 years, and I am ashamed to say that at that point of time we didn't have an equivalent option or a better option available to us. Today we have it in the shape of something called as Dynogest, which has equal efficacy, can also be administered in the long term, and is efficacious for a period up to 5 years, which makes it an ideal agent for usage, especially in an adolescent population. We have also had COCs, like we said, but the relief from pain and reducing the progression of disease is nowhere comparable to the other 2 options which we have just talked about. So let's start by critically examining how effective is our treatment. And as a surgeon who has operated on endometriosis, What I wish to particularly know is whether this is equally efficacious as a surgical option or it is not comparable and it is just like a palliative treatment. And if you go back to literature and you look at all the randomized trials which have been done, you will find that endometriosis related symptoms like dyspareunia, pelvic pain, dysmenorrhea, and premenstrual pain, when you compare after a period of about 20 to 24 weeks, are reduced to less than 10% when you compare to the beginning of the start of your therapy. And this is right across the board for adults as well as for adolescents. So how do we monitor these patients? How do we follow up these patients? Is there some blood test that we need to do? Is there an ultrasound recommended? The simple algorithm for management recommends that you review these patients every 6 months. You do not need invasive blood tests. You don't need to do biochemical monitoring. All you need to do is do a simple ultrasound and you administer a questionnaire which asks the patient certain leading questions. And this is there as part of the endometriosis vision books, clearly available, freely available. You can find a copy on my website as well, and you're free to download it from pratiktambe.com. When we talk about follow-up and when we talk about management with medical management, the key thing for us again to examine is whether this is endorsed by guidelines. And the simple answer is there is a special society which looks after only endometriosis. In fact, it's called the World Endometriosis Society. They have an annual conference every year, and many of the people who attend this conference and present there are not OBGYNs like you and me or endoscopic surgeons. They are people who work in molecular genetics at a cellular level, pharmacologists, people who are actively engaged in research, and they have come to a diagnosis that the best treatment that we have available today from all points of view, and especially for an adolescent patient, is Dynogest. It's recommended as the primary therapy and it's recommended without laparoscopic confirmation. So tomorrow, if you are challenged or questioned, or somebody says that you are practicing in an empirical fashion just because some company MR has come and told you to write this product, no, that is not the case. It is evidence-based, it is recommended by large bodies, and it is also endorsed by several key opinion leaders at Foxy. The last part of my talk is to talk about counseling for both patients, the guardians, and caregivers. Because we know that endometriosis is a lifelong disease. It is like hypertension, it is like diabetes. You can keep it under control, but you can never completely cure it. And that is something which has to be impressed on both the patient and her caregivers. There is a 7-step algorithm for counseling patients who have endometriosis. That's a separate talk by itself. So I'm not going to talk about it here. But what I will impress upon you is that we need to sit the patient down, spend some time with her and her guardians, and ensure that they understand that endometriosis is a chronic disease. It requires holistic care over the entire reproductive lifespan of the girl. If she is diagnosed at 15, she has to be told that until she reaches menopause at the age of 45, 50, this may recur, it can progress, and the progression and the staging may vary as per the age and individual characteristics or the physiology of each individual patient. Fertility is something which needs to be addressed as part of this counseling, but this is not something which may be immediately important for her. At some point of time, an adolescent girl with endometriosis is going to get married. They will need to inform the in-laws that she has this disease. So immediately the question will be, doctor, can this girl conceive? ये माँ बन सकती है कि नहीं? What are the chances of her getting pregnant? Is she going to require IVF only? Can she conceive naturally or not? So these are all the questions which will come, and they may not come immediately in the very first counseling session. So we need to be patient. We need to give them time, and this may be something which we need to talk about over a long period of time with repeated sessions. The next question that we need to answer is whether it is safe to give this drug to adolescent girls as well. Has this safety been proven, and how long can we safely give this drug? And the simple answer is, if you look at population data and studies which have been done, you can give this drug safely for up to 60 months or 5 years without a break. Remember, for combined oral contraceptives which are being taken for contraception, we used to popularly tell our patients, take it for a certain amount of time, then give a little break in between for 1 or 2 months, where maybe you use a barrier method or you use some other method and then restart, because we know that COCs are more prone to causing patients problems like venous thromboembolism, etc. You'll be surprised to know that for Dynogest, there is no such recommendation. You can continue it safely without a break for as long as 60 months. And there is data from good studies which shows that it is very safe and effective. In fact, one of the first studies which came out way back in 1993 or 94 was from Japan, a country where they have very high incidence of endometriosis, and they have used it for up to 60 months in a Japanese population without any issues. As far as prevention of recurrence is concerned, you can see from this table very clearly that there are only two options which we said were highly efficacious. One was GnRH analogs, which I, as an endoscopic surgeon, have prescribed left, right, and center. But unfortunately, we cannot give it for longer than 3 to 6 months. And ideally, in an adolescent, we should avoid it as much as possible because of the effect on bone mineral density. You'll be surprised to know that after 3 years, you will have a recurrence rate of as high as 49% in patients who are given OCs, and as high as 50% after 5 years in patients who are given GnRH analogs. Whereas for Dynogest, after 5 years, the incidence of recurrence is only about 2 to 3%. I think that speaks volumes about the safety and efficacy of this drug. We've already answered the question of whether we should give GnRH analogs instead, and these are some slides pertaining to that. You'll find in the first 6 months of therapy, the efficacy as far as the visual analog scores are concerned is equal between Dynogest and GnRH analogs, but it's not recommended for longer than 3 to 6 cycles. And as we said just a couple of minutes back, it is not recommended in the adolescent population owing to the effects on bone mineral density. These slides are just there to complete the entire discussion. And the last part of the talk is to talk about future fertility concerns in this adolescent population. Ideally, what we should be doing is we should be creating mass awareness that these young girls can freeze their oocytes, and later on, when they get married or they find a suitable partner, you can go ahead and perform a frozen embryo thaw cycle. This is something which all of us as OBGYNs are aware, but often we are guilty of not offering this choice to our patients, many of whom may not be aware about it. The poster girl for cryopreservation, of course, is Diana Hayden. She was the chief guest at the inauguration of the Bangalore AICOG, which I think seems like it was decades ago, but it was only just 1.5 years back. Because of the corona pandemic, we currently can't have any physical meetings, but these are pictures from that particular occasion. And this is our then president, Dr. Nandita Palshetkar, one of the pioneers of fertility preservation in India, talking about the various indications. This was at the South Zone Foxy in Coimbatore. Again, this seems like it was decades ago, but it was just 1 year back. I'll close by giving you a few simple take-home messages. Endometriosis is a disease for which we unfortunately have no permanent cure. There is new evidence coming up every 6 months. There are a lot of recommendations which are coming up, some of which are empirical. Many of these are based on randomized trials and meta-analyses. We all are aware that it's associated with impaired ovarian reserve and poor oocyte quality. Surgery, therefore, is to be avoided, especially in the adolescent age group. With a presumptive diagnosis of endometriosis, we are well within our rights to administer medical treatment. If the patient responds, your diagnosis is proven and you can continue it safely and efficaciously for up to 5 years. Having said that, good counseling and addressing future fertility concerns is also of paramount importance, and it's something which we should all offer our patients. Suicide cryopreservation is very easily available in most major metros in India today, and we would be doing a disservice to these young girls if we didn't offer these to our patients. I'll close by saying, in the immortal words of the French philosopher René Descartes, that common sense is the most widely shared commodity in the world, for every man is convinced that he is well supplied with it. Most of the things that I have talked about today will seem like simple and common sense to you at the end of this talk, but it's important to observe these in a structured, systematic, and disciplined fashion. Thank you very much to the organizers for having me here today.
Thank you, Dr. Pratik, for a wonderful and very fabulous and very informative talk. Most of the time, girls come to our clinic, we consider it is most of the time psychological, because lot of changes are occurring in the adolescent girls. But you have already told many points. It's very important that counseling is very, very important for these girls.
प्रतीक जैसा कोई नहीं, इसके ऊपर भी हम एक टॉक दे सकते हैं, और हम टाइम पर हैं, एंड पैनल को स्टार्ट किया जाए.
Thank you. I think we'll take questions later.
Thank you, for giving me the opportunity to be the part of this webinar. Thank you, ma'am. Thank you, Dr. Pratik, again.
Concerned with the time, and ये जो पूरा प्रोग्राम एक्चुअली रखा गया है, थैंक्स फॉर द ऑर्गेनाइजर में अर्चना वर्मा एवी ही है. we want to listen to Pratik and want everybody to listen to it. And adolescent से ही अगर आपका endometriosis पे पकड़ अच्छी बच जाएगी, so you will be managing endometriosis better and better.
Thank you, Dr. Ashna.
Thank you very much, ma'am. Can we have the introductions for the two moderators for today, please?
I'm supposed to take this.
Hello.
Okay.
Yes, ma'am. Please go
Okay.
ahead.
Yeah.
Dr. Simon, I'm supposed to invite the panelists or moderators for this panel.
हम आपका टाइम ओवर हो गया, डॉक्टर सिमोन.
Oh yes, sure.
Please do the favor.
Good evening, friends. First of all, I would like to thank Dr. Archana Verma ma'am for having me here, and it's my privilege to introduce the two most eminent moderators for this panel on hypertensive disorders in pregnancy. We have Dr. Asha Jain ma'am. She's the director, SMSA Raipur. She's the medical director, CPRS Raipur. She is the secretary of IMA Raipur and president Raipur Obs-Gynae Society for year 2018-20 and 2020-22. She is the president of Rotary Club. And next moderator for this panel, we have Dr. Varsha Dhade. She is the director, TOG Hospital, Nasik. She is the member, Imaging Science Committee, and she is the founder member of State Justices. And this is the much needed panel where we will know the latest in the management of hypertensive disorders. And thank you once again, organizers, for such wonderful academic feast. And Dr. Pratik sir, it was a wonderful talk. We really enjoyed. Welcome, my moderators.
Hello everyone, am I audible?
Thank you, madam.
Yeah, am I audible?
Yes, ma'am. Please go ahead.
Okay. My sincere thanks to AMOX President as well as FOXY President. I would like to thank Dr. Archana Madam, our Indira of FOXY. What do we call it? By a sweet name to her, Indira. And I would like to thank Dr. Pratik, a perfect, a sincere and a disciplined man of FOXY. I would like to welcome my panelists, Dr. Yashodhara, Dr. Shashibala, Dr. Alka, Dr. Mamta, Dr. Saroj, Dr. Pradnya and Dr. Ritu Arya. I would like to welcome Dr. Asha ma'am. Is she there? Dr. Asha?
If we have the CV slides of the panelists, they can be formally introduced.
Yeah, Dr. Sana, please, yeah. Share the slides, please, for me.
I know,
We will quickly go to the...
यहाँ पर
Case scenario.
ये आ गई ना इधर से इधर आपको रहना है
Yeah, Dr. Shashi Bala is from Gwalior. Next. Dr. Ritu from Ghaziabad. Dr. Alka ma'am from Jabalpur. Dr. Mamta Dagar from Delhi.
Dr. Mamta Dagar, the Dynamic Secretary of AOGD. Dr. Saroj Agrawal, the girl from Ludhiana.
Agarwal. Dr. Pradnya Suryavamshi, she is from Raipur. And Dr. Ritu Arya, Mittal Arya.
Okay. Achha, okay.
From Gwalior, yeah. Welcome everyone.
Yes.
This is a simple panel discussion on hypertensive disorders in pregnancy. We do it day to day. And I have 4-5 situations where we have to discuss the cases. Yes, ma'am. Welcome, Asha ma'am. Are you there? Yeah.
Dr. Varsha ma'am, your voice is quite low. Your volume is quite low.
Hello. Okay. Now, how is it?
Yeah, much better.
Am I audible now?
Yes,
Yeah.
please go ahead.
The first situation is 21-year-old primary gravida is at 34 weeks of gestation. She has had an uneventful antenatal course. She has been brought in an alert state of consciousness with the history of one episode of convulsions at home. Her BP in the labor ward is 210/114 and she has 3+ proteinuria. She is not in labor. So the first question goes to Shashi Bala ma'am. What would you do in first 30 minutes of seeing her and the differential diagnosis?
Thank you, Varsha ma'am.
Shashi Bala ma'am?
Yes. Yeah. Thank you very much for inviting me on this panel. And as you suggested, she's a primary. She is a primary gravida with BP, and she has had one convulsion incident, and she has had proteinuria. So all these things point that she is a case of eclampsia, and we have to actively manage her. And as soon as we see her, first we have to put her in a left lateral position. We have to see for her airway so that the tongue does not go down and block her airway. And we have to see for her oxygen. Next, we have to control her seizures, which is the most important. So number of seizures, only one she has got. So we should take pains that the seizures should not be repeated. So immediately we'll give her magnesium and sulfate and we'll manage her for that. And IV line is already there, fluid monitoring and restriction. It should not be a very slow fluid should be given. And since she's also having 210 by some blood pressure, then we have to manage her by antihypertensives. And then we'll send her all for investigations. In the meantime, we would have put in a Foley's catheter to see for a urine output. And we feel for her reflexes. And then we'll take pains that she should go into labor because she's already 34 weeks. So we'll take pains so that she delivers fast. So that will be the initial.
Would you like differential diagnosis with her?
I did.
Would you like to comment on different diagnosis?
Yes. About the differential diagnosis, we have to first rule out whether she is going into cerebrovascular accidents or some infections like meningitis or encephalitis, or she might be having some space occupying lesion, or she might be thrombotic thrombocytopenic purpura case, or she can have that some organ failure, or she's going into that vasculitis, or hemorrhage, cerebral hemorrhage is there. All these things they can give a good DD. And we also have to see metastatic gestational trophoblastic tumors also sometimes they give rise to seizures. So or simple there might be electrolytic imbalance. So that can also lead to seizures. We have always seen that sodium potassium imbalance can always lead to all this kind of scenario. So that is
So this
yes.
yeah, this excellently told the other differential, but the first and foremost diagnosis is eclampsia, where we have to treat it. And what is the anticonvulsant of choice in eclampsia? Can you highlight it?
Yes. Yes, magnesium sulfate is the anticonvulsant of choice in eclampsia, because we have seen compared to diazepam and phenobarbitates, this has the sparing neurological effect on the baby also. It saves the baby also, and it acts very fast, and it is easily available. We see to it that it is available very. We have kits in the labor rooms, and so magnesium sulfate is the drug of choice. You want me to elaborate the
The
doses?
next question is to Dr. No, let us go to the next panelist. Dr. Ritu Arya, can you comment on eclampsia kit and the maximum dose quickly?
The kit we should have anticonvulsant, which is magnesium sulfate, antihypertensive, IV fluids, and various syringes of 20 ml and different sizes of. There are certain numbers that we have to put in those kit, along with the sample collection and Foley's and everything. This kit should be available in every ops ward that we are dealing, wherever we are dealing with obstetric patients. Hello.
Yeah. Hello. Okay. Can you, Sana, please, next slide. So the multicentric trial of 1,687 women were taken, was done, where the 52% low risk of recurrent convulsion when they have given magnesium sulfate versus diazepam, and the other is magnesium sulfate with phenytoin. The trial was showing that there is 67% lower risk of recurrent convulsion. So it is proven that magnesium sulfate reduces the risk of maternal and perinatal morbidity and mortality. Arya ma'am.
Yes, ma'am.
Can you go ahead with giving the maximal dose?
Okay,
As we all
the
know,
loading dose is 4 gram. That is, if we are taking 50% of the solution, so it will be around 8 ml. We take it in a 20 ml syringe. So 12 ml is 12 ml is normal saline, and we give it over 10 minutes. So basically, it is 1 gram in over 1 minute, and then in the Pritchard regime, 5 grams is given in both the buttocks. Another thing that can help is like we can, after loading the 5 gram, we can load 1 ml of 2% lidocaine. So when we are giving, it will be less painful, and we have to repeat the doses after every 4 hours. Till 24 hours after delivery or 24 hours after the last fit. But to monitor these, we need to see that the toxicity is not there. So we need to see the patellar reflex, urinary output, and respiratory rate. Patellar reflex should be present. Urinary output should be more than 100 ml in the last 4 hours. And as far as respiratory rate is concerned, it should be more than 16 per minute. So if any of them is not there, then we don't give it. There is an IV schedule also. After giving the loading dose, we can continue with 1 gram per hour. In that, we give 6 gram in 500 ml, and we give it over 6 hours. So we can continue the same for 24 hours after delivery or 24 hours after the last fit.
So the precautions you have to take is when you give a rapid intravenous 4 gram, which has to be given very slowly because it might lead to respiratory failure.
It should be given over 10 minutes, ma'am, because it can then lead to respiratory.
Has to be very slow. Okay. Next question is to Alka Agarwal, madam. What would you do if she had another convulsions in 15 minutes of having administered the IV loading dose of magnesium? And what you would do if she had another convulsions 2 hours after the IV dose of magnesium? Over to you, ma'am. Alka, ma'am. Alka Agarwal.
सर को जरूरत नहीं आपकी
Dr. Alka, ma'am.
Yes, thank you very much. I am very thankful to Dr. Archana Verma for giving me this opportunity, and Dr. Pratik Tambe and Amox. And good evening to all. If patient is having recurrent kind of seizures, then again we have to repeat the dose of magnesium sulfate 2 gram IV. We have to repeat it, and uh, it has to be repeated after 20 minutes of giving loading dose.
थोड़ा सा खोलना बेटा, एकदम पूरा मत खोलना.
Magnesium sulfate is repeated.
Yeah. But if it is within 15 minutes, we need not repeat the dose. It's only after 20
More
minutes.
than.
कुछ light.
Yeah, we are concerned with the repeated convulsions, madam. So, repeat dose of 2 gram is mandatory when she has convulsions after the first magnesium sulfate dose, as well as you can go for diazepam, phenytoin also given, and this delivery is conducted under general anesthesia. Otherwise, the rest of the cases we give a spinal anesthesia. Hello, Dr. Saroj madam. What clinical pointer should from the CT scan in the patient with eclampsia, dose of magnesium sulfate, use, effect of neonatal outcome? Can you highlight on it?
Hello, if the patient has had another fit after 15 minutes, and 2 grams of dose of magnesium sulfate has to be repeated. But at the same time, if the patient develops a fit again, we would really order a CT. And or if the first fit has occurred 24 hours after the delivery. So that also prompts us to have CT and have a differential diagnosis apart from the eclampsia. The patient may be having meningitis, encephalitis, some rupture of cerebral aneurysm, or she may be having some kind of SOL, like some kind of granuloma in the brain or cerebral tumor or neurosis. So all these things have to be kept in mind.
Yeah, and the magnesium sulfate has a neuroprotective effect. So for the neonatal
magnesium sulfate is definitely to be beneficial because it will be benefiting the fetus also. It's neuroprotective for the baby, and it has been seen that it protects even the child from the cerebral palsy. So even if it is given half an hour before the delivery, magnesium sulfate plays its role, being a neuroprotective child.
Okay.
So definitely like to give magnesium sulfate to such a patient.
Thank you, madam. Sana, you have to switch to the situation 2, and I will hand over this mic to Dr. Asha. She would be taking the situation 2, case 2.
Thank you, Dr.
Asha,
Varsha. Thank you. Can you hear me all?
Yeah.
Yes.
Okay.
Yeah.
I'm sorry with the trouble in my car, I couldn't really join in time. So we will take the second case. What's happening? Go back, please. Go back, slide. Are we still stuck at eclampsia? We need to go to situation 2.
No, we have to go to next.
Next case.
Next.
Next slide. Next slide. Yes. There's a 34-year-old Gravida 2 abortion 1 who has had an uneventful course until now under your care. And now she is seen at 32 weeks gestation. Her blood pressure is 166 by 110 millimeter mercury and 2+ proteinuria. Next, please. What are you going to do to her? Dr. Pragya, what are the priorities in this case?
Thank you, madam. I would like to say that 2 things are there. Firstly, the mother is having severe hypertension, and secondly, baby is not mature. So we have to give enough attention to both of them. Firstly, we will control the blood pressure, prevent the seizure in the mother, and simultaneously do things to for the lung maturity of baby. For prevention of seizure, as it is the severe PIH as case is showing, so there is high risk of convulsions. I think I am audible. So yes. For this, we will do prevention. For the prevention of convulsion, we will give prophylactic Maxerve therapy. Plus, we will do reduction of blood pressure. And as this is nearly it is going into the severe hypertension, we can start with the IV drugs, labetalol or whatever is preferred in our circumstances, and then we can shift it to gradually we will reduce, and then we can shift it to the oral medication and simultaneously Batnesol cover to the baby, and plan if everything becomes normal gradually, and within 7 days if everything is okay, we will do color Doppler and all things for amount of Liker and the color flows to the baby, then we can go ahead with the pregnancy. But if there is any end organ damage or there is blood pressure is not controlled, then we have to deliver the baby, because this is studies has shown that after delivery of baby the reversal of complication occurs very fast, so patient improves very fast. So this would be
is BP important? How soon would you like to bring down the blood pressure?
Blood pressure control is very important in PIH patient because it can lead to many complications like left heart cardiac failure and convulsion and hemorrhage in the brain, end organ complication, renal failure, hepatic complication.
What I'm saying is, I'm asking you a specific question. How fast will you bring down the blood pressure? How fast will you bring it down?
It should be gradual, but if it is severe hypertension, like in this case, then in 1 to 2 hours, we will reduce the blood pressure to moderate level, like that is 160, within 160 to below 160 hypertension systolic, and within 110 diastolic. It should be cut below this level. But after that point, we have to be gradual over 1 to 2 days, 24 to 48 hours. After this, we have to take it between range of 150 to 90. So then the reduction should be slow. Initial 1 to 2 hour, then
just take एक one liner बोलो कि हमको बहुत जल्दी नहीं है, it needs
right gradual reduction.
So there's going to be a gradual reduction. And next slide, please. Will you keep her with you? I already know have a tertiary center, but supposing you didn't have a tertiary center, in that case, would you admit her, keep her with you, or shift her to a tertiary center?
See, madam, if a patient is not at tertiary center, then there are two things. Patient is going to deliver right now, then we have to give her emergency care of delivery and then shift the baby. But if there is time, then we should shift her baby in utero. We should shift the patient to a safe place, because it can complication can occur any time in this patient. So it should be shifted with initial management of blood pressure.
Okay, what complication do you expect in the mother other than eclampsia and cerebrovascular accident?
Yes. When mother, other than eclampsia and cerebrovascular accident, there can be cardiac failure, there can be renal failure.
You are the wife of a physician. Abruptio placentae, don't forget you are a gynecologist. Okay. Next slide, please.
That is on the baby side.
No, but it's happening to the mother, right?
Yeah, that is on that part.
Next slide, please, Sana. Next slide. So, next slide, please. Does antihypertensive change the course of the disease?
No, basically it does not change the course of disease, but complications. We have to prevent for complication that we were talking just before.
Okay. So then we go to the next question. Next slide, please. Next slide, please. So this is the take-home message that you have to reduce the diastolic blood pressure to 10 to 15% or less than 110 millimeter mercury over 30 to 60 minutes. Our goal is not to normalize, but gradual control, because if you bring down the blood pressure acutely, then the fetal circulation is compromised and we may lose the baby. So next slide, please. These are the various drugs that are available: labetalol, hydralazine, and nifedipine. When I was a PG student, the Depin capsule used to be punctured and kept under the tongue of the mother. But no more. Now you have to give a tablet. You do give it with a sip of water. You do not give the capsule after puncturing it because you don't want an acute drop. Next, please. In a patient who is a chronic patient of hypertension, she has come to you at 160, 110. Then what are the preferred drugs in a case of chronic hypertension? Pragya?
Yeah, methyl dopa still is drug of choice in pregnancy because with the methyl dopa there is chances of fetal circulation are good because we are handling with the, both of them. Then secondly comes the labetalol, and for the definitely angiotensin blockers are avoided. These are category D drugs. So we are safely, we are in hand our labetalol and nifedipine and this methyl dopa.
So because your husband is a cardiologist, I'm bringing you a question out of nowhere. Out of nowhere, listen. There is a woman who is stabilized on Amlovas 80 when she is non-pregnant. Now you find out she is pregnant. Will you change her drug?
Yes.
Yes, yes.
Common thing that happens.
No, we change, and even cardiologists know this.
No, that's what I'm saying. Will we change the drug, and then what will be the agent of choice?
Initially, labetalol and methyl dopa. Our agent of choice are these two.
Okay, thank you. Next slide, please. Now she is 34 weeks, and we have to plan whether we want to wait or we want to deliver. So Dr. Yashodhara Madam, Namaskar, and this is for you. What factors would make you deliver this woman urgently?
Good evening, madam. 32 weeks or 34 weeks है मैम?
34 weeks है मैडम.
34 weeks pregnancy है, और if she is having eclampsia or
no, she doesn't have eclampsia. She has 2+ proteinuria and 166 by 110 mercury blood pressure.
Okay. So, madam, since she is a case of severe hypertension, hypertensive disorder in pregnancy and 34 weeks. If we think from the point of view of 34-week gestation fetus, it is well mentioned that 34-week gestational fetus is very much fit for survival after delivery. Almost 34 to 36 week gestational age babies survive 100%. So, if we want to deliver her from the maternal point of view, we can deliver her. It is safe for the fetus. But if 34 weeks and 166, 110 and she is not having any impending eclampsia sign, patient is well controlled. After giving labetalol, her BP comes down, and and her proteinuria also reduces, and there is no further advancement in the disease in the form of headache, in the form of pain in abdomen, or in the form of deterioration in the liver function test, or in the form of blurring of vision. All of them, if they are not present, then we can give her steroid for 24 or 48 hours, and thereafter we may go for delivering it. And even after that, if patient remains under control, then we may prolong this pregnancy to 1 week. But otherwise, if any of the complication develops, then definitely we can go for delivering at 34 weeks. There is no problem in delivering. Our NICU will take care of these babies very well, and hardly 1 week stay is reported for 34-week gestational age babies. Now, as far as the delivery is concerned, the mode of delivery is very important for these patients.
Madam, wait, we will go to the mode later.
Okay.
Let me ask you once that now her BP has, you've given her nifedipine or you have given her labetalol, and her BP has settled very well. So if you have decided that yes, we are going to wait, how will you monitor maternal and fetal well-being? What are the tests that you will be doing, and what will be the frequency?
Okay, so if we have decided to keep the patient on conservative management, then definitely daily patient's vitals monitoring, BP monitoring is 6-hourly monitoring is a must in this case. And the investigations which we carry out are all those investigations which are related to the organ, multiple organ damage like liver function test, SGOT, SGPT, serum LDH, platelet count, and urea creatinine if it is available. And of course, cognition profile, we may go for it. So these investigations we will carry out. Apart from this, from
Madam, what will be the frequency? The frequency of these tests. How often are you going to do the blood tests?
Bi-weekly is recommended. Bi-weekly, after 3 days, we have to repeat it. And obstetric color Doppler is a very, very useful tool for monitoring fetal well-being.
What about NST?
NST, of course, we can do. NST is very good tools that can be done, that we people are doing daily on these patients with the help of the CTG machines are available in most of the labor rooms nowadays. So we are doing CTG daily of these patients. And at the same time, patient is asked to look for the DFMC. And while we perform the ultrasonography, amniotic fluid adequacy is a very good indicator that yes, the baby is going well and fetal movements are there and NST is reactive, and color Doppler is, if it is showing good flow in the uterine artery, there is no MCA parameters are normal. So by observing these things, we can keep this patient on observation, and in the tertiary care center only, where an ICU facility is available and OT is available for 24 hours.
Thank you, madam. Dr. Mamta, one last bit from you, that the patient's blood pressure has come down absolutely to normal and she is showing no signs of progression of the disease. Then when will you deliver her? She's 34 weeks. How long would you like to wait? Just a week or more?
See, if she has crossed 34 weeks and though her BP is normal, we do not attain, in fact, by prolonging her pregnancy if she's a case of severe preeclampsia, in a case of severe PET, because the maternal risks are more, and due to severe preeclampsia, as benefit versus risk situation, as a risk of prolonging the pregnancy, because prematurity is not going to harm the baby. So it is a wise decision again to revise. However, if there are certain, personal factors, then under close monitoring for a week, she can be monitored by every 48 hours. Thrice in a week, you need to do the hematological profile, the CBC and hemogram and platelet and LDH, and also her kidney function test, creatinine and SGOT-PT. And CTG daily, then ultrasound, biophysical profile twice a week.
How long would you wait? 1 week, 2 weeks?
I will not wait a severe preeclampsia.
So this is 166, 110. With labetalol, her blood pressure has settled down. Her proteinuria is remaining where it was. No parameters are going bad. All your testing, everything is the same. So how long are you going to wait?
37 is the ultimate, when we need to take the call. That too under strict monitoring, 37 weeks.
Now, if that patient says that, blood pressure to theek ho gaya, humko koi takleef nahi, hum ghar ja rahe, what would you do then?
Definitely she is not allowed to go home at 37 weeks still, we cannot take so much of risk. She needs to be delivered, because even a case of mild preeclampsia, we need to take a call at 37 weeks, because again, Dr. Asha, the harms will be more to the mother and baby than we need to really carefully counsel the woman, advocating her the risks of prolonging the pregnancy, harm to her, the risks of complications of severe preeclampsia.
So thank you, Dr. Mamta and Dr. Yashodhara. And this is the summary. This is what we all know. That if something bad happens, she gets sudden hypertension, eclampsia, pulmonary edema, abruptio, oliguria, imminent eclampsia, headache, visual changes, platelet counts go down, there is upper epigastric pain, or creatinine rises a little bit, then you take out the baby immediately. This we all know. The problem is that how long we can prolong when nothing is going bad. So I think with this we shift to the next slide. Next slide, please. Sana. Where's Sana?
Yes, she has even.
Yes.
She has changed
Once
it.
more, click once more. So this question now goes back to Dr. Shashibala. How will you optimize neonatal outcome in preterm deliveries of women with preeclampsia?
See, to optimize the fetal outcome, we have to, depends upon the period of gestation of delivery, at what period she is delivering. So prolongation of pregnancy is definitely indicated, but we have to see that we do not increase the maternal risk. So to prolong the pregnancy, mother is not at risk, we give her steroids. They have a significant role in prolongation of pregnancy, not prolongation, but for fetal lung maturity, so that the survival of fetal neonatal outcome is increased. Now, steroids, they can take care or reduce necrotizing enterocolitis, or sometimes there is intraventricular hemorrhages. So primarily, steroids act on the stimulate the sort of lung maturity by production of surfactants. So it is a microvascular permeability is increased. Now, to make a choice which steroid to give, we prefer dexamethasone because it is easily available and it acts better than betnazole, and it has to be given. It can be given intramuscularly. We give around 12 hourly, and and orally also it can be given. So it is very easy to administer. 32 mg 12 hourly we can give, and if at all we have to give betamethasone, then that has to be given repeated after 24 hours. 2 doses are enough. So that
Next
takes
question,
care.
please. Next question. Ma'am, as far as I know, we give 6 milligram of Dexona 6 hourly, or we give 8 milligram 8 hourly. We do not give 32 milligrams, we do not.
Orally total, okay.
Okay. And if the decision is to wait more than a week, then would you repeat the steroid or not?
No, there is no need to repeat the steroid because that won't help much. 34 weeks and we have already given her, so repetition is not advocated. It has been seen that it doesn't help much.
Next question. Now this baby who is born at maybe 34 and a half weeks, and the nursery is at a different center, the NICU. How should this baby be transferred?
If the baby has to be transferred, then we have to transfer the baby in a specialist center with us in a well-equipped ambulance, where there is a portable incubator is there and specialists should accompany that. And if you are saying it is 34 weeks, then also we have to take care that the baby reaches in time, and then proper care, this hypothermia and all are taken care of.
So ideally the pediatrician takes over once the baby is born.
Yes.
That's it. You hand over after the birth. So next question to Dr. Ritu. What type of anesthesia would you like to give?
Ma'am, for these patients, we like to
Next
give regional anesthesia. For these patients, we like to give a regional anesthesia, epidural, and if epidural is not possible, then spinal anesthesia. The only contraindication of not giving a epidural is when the patient is in DIC or the platelet is less than 50,000, and if the patient has status, then we have to give a general anesthesia to them.
Next question. What are the risks of general anesthesia?
The patient has fits, there can be a laryngeal edema which can lead to a difficult intubation, and because in general anesthesia we'll be giving drugs that can interact with other anticonvulsants we have already given, and relaxation can be there. There can be increased chances of postpartum hemorrhage also.
Thank you, ma'am. And Dr. Varsha,
Yeah. Yes, ma'am.
please take over the third case.
Yeah, Sana, just switch on to the next slide, please. Next slide. Yeah, now we have the situation 3, which is very simple case. 26-year-old primary gravida who has had an uneventful course until now under your care is seen at 28 weeks of gestation. Her blood pressure is just 140/92 and she has not have any symptoms or proteinuria. Dr. Alka ma'am, what is the diagnosis? Next slide, Sana. Yeah, go ahead, Alka ma'am.
Yes, she is 28 weeks of pregnancy and her BP is only 140/90 and there is no proteinuria. So she is a case of gestational hypertension because previously she was normal, but now when she has come at 28 weeks, she has developed blood pressure of 140/90. So we label her as gestational hypertension.
Yeah. Would you like to admit this patient?
No. I will not like to admit this patient. I'll advise her all the. I'll ask her to manage at home. She should improve her lifestyle, and she should take calcium, iron, and antioxidants, vitamin D, and she should be She should be mentally at peace. And then again, and she should monitor at her BP at home. If second time also the BP is more, then I like to give antihypertensive. Otherwise, I will not like to admit her, and nor I will like to give her any antihypertensive immediately.
Next question. How would you advise this patient regarding salt restriction and bed rest?
No. Salt restriction is not required at all.
Okay.
And because it's a gestational hypertension has just developed, and we don't advise salt restriction in gestational hypertension or even preeclamptic toxemia. Only in chronic hypertension salt restriction is advisable.
Next slide. Next question. Yeah, slide please. Will it be beneficial to give the woman sedative? Alka ma'am?
I don't think sedatives are required at this time. She can control herself by doing pranayam and yoga and all, and by relaxing, she can do relaxing exercise, and it's a start of the BP, and it's very less, 140/90 only. And I'll ask their relatives also, her husband and her in-laws also, to give her the best atmosphere at home, so that she should be relaxed. In that way, her BP may come down if it is once, or it may remain same. But sedatives are not required at all.
Okay. Next question is to Dr. Mamta. Would you like to prescribe her antihypertensive? Dr. Mamta.
Yeah. She is a case of gestational mild hypertension, and evidence doesn't say that there is any role of starting antihypertensive therapy in case of mild hypertension, that too in gestational hypertension. So she will not be benefited with antihypertensive treatment. Moreover, she may get harmed, because of the hypoperfusion, placental hypoperfusion, which may result as a result of starting antihypertensive treatment at this mild hypertension, and it may lead to uterine hypoperfusion, in fact. So it is not beneficial, and there is no role of antihypertensive at this blood pressure of 140/90 to mild hypertension, that to gestational hypertension. Okay. There is a role of starting antihypertensive therapy in case of gestational hypertension, if the diastolic blood pressure is repeatedly more than 100 millimeters of mercury. Not between 90 to 100.
Okay. Next. At what level of blood pressure do you start? That is, you have answered, that is 100 millimeters of mercury, that is diastolic. If she were in labor, would you give her magnesium sulfate?
Okay, again here my say is that in case of gestational hypertension and mild hypertension, it has been seen that though the administration of MaxSulf is associated with reduction in the eclamptic fits in these women, but per se the perinatal outcome and maternal morbidity is not improved. So there is no improvement in the perinatal outcome with the administration of Maxil. However, it may result in reduced incidence of seizures.
Okay, next slide, please. So to conclude, there is no benefit from salt restriction, as Alka Madam has rightly said. No role of bed rest or sedative in preventing severe hypertension. Early initiation of antihypertensive will reduce the risk of severe hypertension, but does not change the outcome and hence not recommended. Antihypertensive could compromise the fetal perfusion, so it is not advocated. Next slide, please. This is the multicentric randomized placebo-controlled trial. Inclusion criteria were uncertainty about magnesium use. The results were significant reduction in eclamptic fits, but number needed to be treated is large in mild preeclampsia. No difference in maternal morbidity and mortality or neonatal outcome. So, magnesium sulfate, as Dr. Mamta has rightly said. Next slide, please. Now over to Dr. Asha Madam. Dr. Asha Madam, take this situation forward.
Thank you. I was muted.
Okay.
A 24-year-old primea gravida was admitted at 30 weeks with suspected preeclampsia. She had 1+ proteinuria on dipstick and a blood pressure of only 110/70 to 130/90, variable. Her 24-hour proteinuria was 440 milligram per deciliter. So what is the diagnosis and what is the treatment? This question goes to Dr. Saroj.
Hello, yes. And because this is very unlikely presentation of preeclampsia, but because the patient is, though her BP, she is mildly hypertensive. Her BP has remained around 130 and 90, which otherwise does not conform to the preeclampsia, but she is having proteinuria. That means she is already having a renal disease. So endothelial damage is already there. And her 24-hour proteinuria is more than 300 milligram, which makes me think that I should admit the patient and monitor. And during the monitoring, of course, I will be really, apart from the routine investigations, I will really be asking her the detailed history, whether there is any history of GDM or diabetes mellitus or any chronic hypertension earlier or chronic kidney disease earlier. Has she conceived by a natural method or she has conceived by artificial method? So all this is history is very, very important in her case. Is she a patient of hypothyroidism or GDM or diabetes mellitus? All this matters. And then I would also like to know the typical history if such a patient develops anything like headache or altered sensorium, or she develops some blurring of vision or scotoma, or she develops some oliguria at the same time, then I'll be more concerned. And I'll start with an intensive management accordingly.
And her blood pressure is only 110/70.
Yeah, but we will keep her under observation for 1 or 2 days at least, so that we come to know that is she having an increased BP later on.
Next slide, please. So she was discharged 2 days later with a diagnosis of mild preeclampsia to be followed up as a outpatient. Next slide. 4 days later, she was readmitted with a home blood pressure recording of 190/120. On readmission, her BP ranged around 130/90. Investigation showed a reactive non-stress test, normal amniotic fluid index, normal Doppler indices. She had no symptom or lab abnormality. Now they have brought her to you because at home her BP was that much, but when she has come to you, you find it is only 130/90 and everything else is normal. So what are you going to do now?
So now her BP is, she is mildly hypertensive. 130/90 is not a very high BP, and she shows that the fetus is all right. There is reactive NST, normal AFI and Doppler index. That means, and moreover, you said that there is no lab abnormality.
Yeah.
So it's just that we can observe her for a day or two, so that we can keep a watch on her BP, because one recording they have said of 190/120. So otherwise, it's just for observation that we would like to keep.
Thank you.
And record the lab indices again and again. Otherwise, she can be discharged 1 or 2 days later with this kind of BP.
Next slide. Next slide, please. On the back, please go back. One slide back. On the evening of readmission, she had eclampsia and the fetus died. Labor was induced with per vaginal 50 microgram misoprostol, but 6 hours later she had 9 convulsions despite the magnesium sulfate infusion. Subsequently, she underwent delivery by cesarean section under general anesthesia due to failure of induction, and she was anesthetized for 24 hours in the intensive care unit post-operatively. So what went wrong? What did we do wrong?
So I think unfortunately, this is unfortunately a case where the eclampsia has occurred first, where the patient has had a fit, and the rest of the disease like hypertension, that means the arterial disease or the kidney disease, which there is proteinuria, that occurred later. So this is unfortunately that atypical case of eclampsia where we missed that patient is having the cerebral damage earlier. And of course the other...
Dr. Mamta, would you like to add something?
It is very unfortunate with the patient, though it is out of blue that we will not say out of blue. It is sometimes as Dr. Saroja said, the course of she has probably gone into the status eclampticus. In the case of atypical eclampsia, in this there is the end organ damages and all the cerebral element is predominating, and that is why the cerebral manifestations have come first before the arterial manifestations, in fact, and the renal manifestations. So it is there in the literature, maybe around we basically have to keep in our mind all cases and all the profiles of severe preeclampsia and eclampsia when we are encountering such patient. This patient probably would not have been discharged, and because she was really having a fluctuating blood pressure. So at probably that point of time with a strict workup, probably we would have picked up something. I don't know that the obstetrician probably went wrong or not, but it happens, and it may happen in obstetrics.
Yes.
Thank you. Thank you. And now we go to next slide, please. She had a normal CT and calculated proteinuria of 36 grams in 24 hours. After weaning from the ventilator on the second day, she continued to convulse in the intensive care unit. However, she had no further convulsions from 48 hours after awakening and was transferred to a normal ward and discharged 6 days later. So that's how the story ends. So this is an atypical case, and it teaches you, the classical teaching that eclampsia is the endpoint of a disease process, starting subclinically and proceeding to mild preeclampsia and then severe preeclampsia, implies that hypertension and proteinuria should precede the onset of eclampsia. This is what we are classically taught. Next slide, please. In contrast to this paradigm, eclampsia can potentially be encountered at the beginning of the disease process before hypertension and proteinuria develop. So the term preeclampsia has been criticized as misleading. In classical cases, the disease usually first involves the arteries and kidneys, manifesting as hypertension and proteinuria before other organ systems are involved. In atypical cases, however, the organ involvement may start with other symptoms, such as cerebral involvement, which presents initially as eclampsia. So this is an atypical presentation of PIH. Next slide, please. So this is situation 5. Dr. Varsha, would you like to take it?
Yes. This is it's a nightmare to have this case. She is 31-year-old G3P1L1A2 at 34 weeks of gestation. seen in the antenatal clinic with her blood reports. The previous evening she had a blood pressure recording of 120/80 and today she's 140/90. She has no proteinuria and the platelet count was directly 80K, that is 80,000. GOT and PT has read 60 and 76 respectively. Next slide please. What differential diagnosis would you entertain in this clinical scenario? Dr. Saroj, over to you.
Because in this case, a platelet count is low, I would also keep ITP in mind. And of course, HELP syndrome, because PIH patients can always really land up with HELP syndrome. So I would really like to order all the tests in this case. In CBC, if you find some kind of hemolysis, some kind of bad peripheral smear, and then thrombocytopenia where the platelet count is less than 1 million per cubic mm, and then if the liver enzymes are changed in these cases, like alanine transaminase or AST and ALT both, if these values they become more like they become to the tune of 75 per 75 units per liter, or if the LDH lactate dehydrogenase is more than 600 units per liter, that means this patient is developing a HELP syndrome. And that makes the picture of the patient bad in general, and the prognosis of the maternal and fetus accordingly changed.
Okay. Next question. Which investigation are to be done to confirm the diagnosis?
Sorry to interrupt, ma'am, we have 5 minutes left.
Okay. This is the last case and 2-3 questions more.
Yes, please. Thank you. Sorry to disturb.
Yeah.
Yeah. Okay.
So the lab test we already mentioned.
Dr. Saroj?
Yeah. So lab test, as I already mentioned, that we have to see whether the enzymes are elevated or the platelets are low.
Okay.
And protein will have to be measured in these cases.
Next slide, please. So this is a frank case of HELP syndrome. Next case. Next slide, please. Sana, next slide. Okay. Are there any specific therapies for HELP syndrome? Does HELP syndrome has any direct maternal and neonatal implications?
See, the steroids have been used.
Hello.
Okay, Dr. Saroj, go ahead. Go ahead.
Yes. Hello. Hello. I'm audible.
Yeah, Dr. Pradnya there. Yeah, go ahead.
HbA1c करने बोलो, sugar repeat करो. उसी हाथ से blood लिया.
Asha ma'am.
This condition.
Asha ma'am, please mute your.
In this condition, sometime in HELP syndrome, steroids are given, but they are not proven that they will improve the outcome. But still, with the administration of steroid, the hemolysis, the platelet rupture, the hemolytic process is little bit reduced, and we would like to deliver her as far as possible with the arranged platelets and all blood product. We would like to deliver her. So the therapy is steroid only.
Okay. So improvement in platelet count and other laboratory parameters with high doses of dexamethasone. There is no difference in maternal and perinatal mortality or rates of major morbidity in the mother or a baby. So HELP syndrome where you have to just go ahead giving steroids and deliver the mother. Next slide, please. So before signing off, I would like to say success is not a final, failure is fatal. It is the courage to continue that counts. Thank you so much, Asha ma'am, to being a great moderator along with me. And thank everyone. Thank you, panelists. Wonderful lady.
Thank you, moderators and organizers.
Thank you so much.
Thank you. Thank you, everyone. Thank you, Pratik sir.
Yes.
Thank you, Archana madam.
Yes, I'm very thankful to AMOX and Dr. Nandita Palshetkar and our guest of honor, Dr. Shanta Kumari Madam, and all the panelists beaming and bubbling with knowledge, and the Dr. Pratik आज मतलब he is always the hero of the any conference, so he was here also. And Dr. Asha Jain, भी हमें आपसे बहुत ही आशाएं हैं, और you please be with us. And, what to say, and science Integra, Sana, your cooperation and coordination is the best, and I really want to do so many programs with you all. Thank you.
Thank you, ma'am.
Thank you, Dr.
We had an attendance of 378 today.
Thank you,
Wow.
panelists.
Three questions of other participants were around 400. That is wonderful.
Wow, wow, wow. Very nice.
Wonderful. Congratulations.
Sir, there are few questions in the chat box. Would you like to take?
Abhi, Abhi, Rituja, please go ahead. And because we were not promoting it as that adolescent conference was going on of Dr. Alpesh Gandhi sir, so हमने बहुत ज़्यादा इसको promote नहीं किया. Otherwise ये endometriosis और हम लोग all this team एक बार इसको करेंगे, बराबर करेंगे और इसको 2000 पे लेके जाएंगे.
Yes.
Archana ji.
और डॉक्टर
high hopes.
डॉक्टर लीला व्यास जी, प्लीज आप आइए और कुछ